Today, we have a patient DC that is presented to the ED on March 25th with the chief complaint of my abdomen hurts. He comes in with subjective fever and abdominal pain for 2 days. For past medical history, the patient has non-alcoholic steatohepatitis with cirrhosis with ascites, encephalopathy, a previous occurrence of spontaneous bacterial peritonitis, diabetes, obesity, and chronic kidney disease. For social history, the patient drinks a couple of beers daily, otherwise non-pertinent. For medications, the patient is taking for his cirrhosis and ascites, furosemide 40 milligrams by mouth every day, spironolactone 100 milligrams by mouth every day, lactulose 15 milliliters by mouth twice daily. For diabetes, the patient is taking insulin glargine 40 units sub-Q every day, insulin lispro 9 units sub-Q 3 times a day with meals, and for spontaneous bacterial prophylaxis due to a previous occurrence, the patient is taking ciprofloxacin 750 milligrams by mouth every week. For review of systems, as per history of patient illness, besides the subjective and fever and abdominal pain for 2 days, all other symptoms were reviewed and were negative. For allergies, the patient is allergic to codeine, which happens, and when the patient takes codeine, the patient has nausea. For physical exams, the temperature was elevated at 100.9. With 81, he is 81 kilograms and 5 feet 4 inches tall, with a creatinine clearance of 25 milliliters per minute using the adjusted body weight of 68 kilograms of the serum creatinine of 2.8. For the physical exam, the patient generally appears as slightly drowsy and confused, the distended abdomen with tender to palpate. For labs, the INR was high at 1.3, low complete blood count of hemoglobin at 8.2, hematocrit at 26.6%, platelets at 98,000, and red blood count of 2.52. He had high complete blood cell count of neutrophils of 72%, white blood count of 13,000, and bands of 6%. For the complete metabolic panel, we had high levels of ethylene phosphatate of 144, ALT at 79, AST at 44, bilirubin at 4.9, serum creatinine at 2.8, glucose at 134. We did have low levels of sodium at 134 and a regular BUN at 23. Then on the patient, it was assessed that the patient had another spontaneous bacterial peritonitis episode. So therefore, it was obtained paracentesis in a couple of blood cultures. They started on empiric ceftriaxone of 2 grams IV every 24 hours and was given albumin 120 grams IV for now, and to continue the home meds. 24 hours report came in at March 26, and the patient received the paracentesis but is still complaining of abdominal pains and chills. The labs were received for the new day, and the complete blood count and the complete metabolic panel showed that most labs were stable. Something to note, the white blood count was elevated or was worsening from 13 to 14,300. The reports came in for cultures, and the blood on the left and the right arm showed no growth to date towards the gram stain. However, the ascitic fluid cultures showed 2 positive gram-positive cocci and pairs and change, with the final culture of 2 bottles of vancomycin-resistant E. faecium. First, it was susceptible to daptomycin at MIC at 1 micrograms per milliliters, linezolid, and nitrofurantoin. It was resistant to ampicillin and vancomycin. Using the American Association for the Study of Liver Disease of 2021 and the Imperial Pharmacotherapy textbook, the primary problem the patient is having is secondary spontaneous bacterial peritonitis. Evidence by the patient shows suggestive signs of infection. Patient showed was complaining of 2 days of fever and abdominal pain, and upon admission and after 24 hours was stable out of an infection of 100.9 and 100.7 respectively. The patient did have an elevated white blood count of 13,000 and 14.3 thousand respectively as well. The patient continues to complain of abdominal pain and chills for 2 days. The physical exam shows positive for distended abdomen tenderness on palpation, and the culture labs that was received from the ascitic fluid culture showed vancomycin-resistant Enterococcus faecium. The patient also had a previous history of spontaneous bacterial peritonitis as well. For therapeutic goals, we want to make sure that infection is resolved, such as white blood count and fever. We're going to prevent or relieve the ascites-related symptoms, such as dyspnea, abdominal pain, and distension. And we want to try to prevent the recurrence of spontaneous bacterial peritonitis. For a non-pharmacologic therapy, we're going to try to advise the patient to taper or to restrict alcohol intake. We're going to restrict our daily sodium to 2,000 milligrams per day and daily monitoring of the patient's body weight. For medication modification, we're going to actually stop ceftriaxone 2 grams IV every 24 hours and actually hold ciprofloxacin 750 milligrams by mouth every week until we resolve spontaneous bacterial peritonitis. We are going to start daptomycin 700 milligrams IV given over 30 minutes every 48 hours with day 1 as for today for 7 days. We are going to continue his home meds for his cirrhosis with ascites and his diabetes. Efficacy monitoring parameters for daptomycin would be resolution of signs and symptoms of spontaneous bacterial peritonitis, such as abdominal pain, distension, or altered mental status. Make sure that infection is resolved, such as fever, chills, and white blood count. Make sure that's normalized. And then repeat diagnostic paracentesis to be performed to make sure the infection has not progressed. For safety for daptomycin, we are going to watch for creatinine phosphatase kinase for rhabdomyolysis, serum creatinine, and urine output. You can also watch out for GI upset such as nausea and vomiting and hypersensitivity. Thank you.